back to talk about some more nursing related stuff. Got an idea, video idea, and I wrote some stuff down on my phone because it is kind of something that I wish I would have known before I became a nurse. Currently, I am a PCU nurse. PCU stands for those that don't know, Progressive Care Unit. So it's kind of like, here's ICU, intensive care unit, PCU is a step down below that, and then you have med-tele, med-surg. So I've been in this considered critical care, so ICU, PCU is critical care. Anyway, so I just have a few things here written down of what I wish I knew before becoming a PCU nurse. The number one thing that I wish I knew before becoming a PCU nurse is, I would say, is the whole contract thing. At least in my hospital, you're supposed to sign a contract if you are going into critical care, and it is usually a 2-year contract. So that is something that in nursing school, I don't think that I was aware of that. I didn't really see that as anything negative though, because I thought, okay, well, that's good. If I sign a 2-year contract, then that means that I'll have a job for sure for 2 years. And you know, nursing is not, it's a pretty competitive field, but at the same time, there's always a need for nurses. So it's not like if you don't sign a contract, you will be worried to keep your job. Like, that's at least where I'm at in a hospital. That's not the case. So I thought, okay, there can't be anything bad to it. There's just, you know, you have to stay within the contract. You can't break the contract. In my hospital, if you broke the contract before the 2 years were up, you have to pay all this money back, and in the thousands. So I knew going into it that it was something that I was gonna keep doing. I was going to continue to work in the hospital, but later on, maybe in another video, I'll talk about like kind of what happened. I ended up just wanting to leave. Okay, maybe I shouldn't say that. If you end up wanting to just try out how the hospital is, if you want to just get a feel for inpatient nursing, then, and you don't absolutely know if you're gonna like it, I wouldn't sign a contract, just because you may be 6 months into it or a year into it. I mean, you would know before a whole year goes up. If you don't like it, you don't like it. So, I mean, at first, being a nurse, period, is difficult. Being nursing school is difficult. You finally passed your NCLEX, you're now working, and you're learning so much at such a high rate. But at the same time, if you don't like where you're at, you're not going to be happy. And I started out in a very high acute PCU floor. It was a cardiac PCU, pulmonary hypertension, CHF specialized. We had lung transplants, heart transplants, but we also had, our bigger thing in the unit was LVADs. If you don't know what an LVAD is, look it up. It's crazy. It's basically that person is hooked up to batteries, and that's what's circulating their blood, and that's how they're alive. You're either they're plugged into the wall, or they have batteries attached to a controller, and you always have to make sure those batteries are replaced and like they're good and everything. Anyway, I'm going off on a tangent here, but I wish I would have known going out of nursing school that I had to make that whatever job I was going to accept, because I went to multiple interviews and I got hired for all of them. It was 4 of them. And I believe all 4 were PCU. I didn't know that by accepting one of those interviews that floor was PCU and that I would have to sign a contract. I didn't know that until my orientation, and that's kind of bad because I had already said yes. And maybe I just overlooked the whole fact. Maybe I was told and I wasn't really sure of what that meant. Maybe somebody told me contract, but I was like, okay, that's fine. I don't know, but just keep in mind, if you're gonna sign a paper, just make sure you know all the facts before you go ahead and you get yourself into something that you can't get out of until 2 years later or more for some people. Yeah, that would be my first thing. Hope I'm recording. Yeah. Okay. By the way, I did a get ready with me. It was a really fast kind of like run out the door, get ready with me. I was gonna sit down and do like a full, really nice detailed, no, I had to run to work. I had check off and it's by time, so I ended up just recording really fast, and then my camera stopped recording, so I don't even know if I'll upload it depending on how much footage I even got. But if anybody's interested, it's gonna be up, I don't know when, maybe this week, maybe next. Anyway, back to the video. The other thing, you're working in a higher acuity level, so that means your patients are sicker, which means they're more prone to having like rapid response situations and codes. So if you're somebody that cannot handle stress or anxiety situations, that you have to act quick and make decisions quickly, and you have to run, if you don't like that adrenaline, if you don't like any of that, and you just want to chill and you want a like nice structured day, which you can still have with PCU as long as they don't code or have a rapid response situation or something like that, then this area, PCU, may not be for you, because you're gonna have to be on top of your patients, on top of your labs. I mean, nobody likes codes, but if you... My husband's calling. Hold on. Hey, babe.
Hey, baby.
Oh, I passed. Yay! I'm filming a video.
You are?
Yeah.
Sweet.
I had things on my mind and on my chest, so... Yeah.
I got you.
What was I saying? Oh, yeah, if you don't like emergent situations, then I would say stay away from that, because you might have them. I mean, they're gonna happen. It's happened to me a lot of times. Sometimes it's not even like, here's the thing, some nurses, they're like, oh no, I don't want to, because I don't want to kill anyone. I don't want to like, I don't want to do PCU because that's like too much responsibility. Like nursing in general, like even on a med tele, med surge, that's a huge responsibility. I mean, it's the same kind of thing. They're just sicker, it's higher acuity. You have to assess them more often. You have to do vitals more times in their shift. You have to, give certain medications like for their blood pressures, IV stuff. When you have an emergency, like I feel like I learned so much from a rapid response situation when we have to call everybody in the room and we're just assessing the patient and we're trying to like think about what's going on and check the patient, think for everything. Like I learned so much. So for me, I don't mind them. They do kind of back you up. You're dropping everything you're doing. You have to just focus all your attention on that person, on that patient. So if that's not for you, then don't get yourself into it, because you may not like it. You will see stuff like that. You will see codes. You will see people die on you, and you may not have that in other units. Where it's third thing that I have here is that you have to speak up when you want a certain order. When you want like, hey, this blood pressure is this, give me this order, give me, or like recommend to the doctor, because sometimes they'll just be like, okay, that's fine. You have to know how to address a doctor and ask exactly what you want and what you need. This goes in general, I guess, in all kinds of nursing. Just have to work with the doctors a little bit differently. You have to maybe contact them more throughout the day to just give them updates. They'll call you a lot. You can't really be shy, and this goes in nursing, period. I am filming a video now, but I can be a very shy person. I've kind of grown out of that. I owe it all to nursing, because if it wasn't for me having to step out of my comfort zone and have to make myself, speak up, like, I've had to conquer that. And so you can't be shy. That will come with time. It will get better. Your phone, oh my goodness. So the phone is the biggest enemy for me and most nurses during your day, because you will be interrupted while you're talking to a patient, while you're putting in a Foley, while you're giving a bath, while you're doing an IV or drawing labs, anything. You could be doing anything, and obviously the person that's calling you doesn't know what you're doing. Your phone is constantly going to be going off the hook. I kind of saw this coming, but kind of not really. When I was in nursing school, I did my clinical rotation, the last one where you're, the whole month with that nurse in their unit. Practicum, yeah. I did my practicum in a med tele, med surge unit, and there wasn't really a lot of phone action. She didn't really get that many phone calls, and I was like, okay, well that's not bad. Once I got on the floor, PCU level, I was losing my marbles. I was like, I want to throw this phone out the window, and I still do. Not this phone, the work phone. Everybody has your number, and everybody and their mom is gonna call you, so just know that that's gonna happen if you want to have a more, if you can't stand it. I mean, I can't stand it. I just can't. but it's there, it's part of the job, it's a way of communication, it's how we know where the patient's, how the patient's care is going to be, you know, better planned if we all communicate with each other. So yeah, there is a purpose to it, but then again, it's just tiring. Sometimes you really just want to go to the bathroom and pee in peace. And I have had patients that are like, oh my god, that phone does not stop. I'm like, yeah, it doesn't stop. So patients notice it too, but you know, you gotta do what you gotta do, right? That you're going to be in the role of a nurse, obviously. You may get blamed for things that have nothing to do with you, that maybe occurred in the previous shift, that maybe has to do with a whole different department, not even nursing. It could be imaging. And some doctors, you know, this patient's very sick, they want a CT of the head or an MRI or something, they want it now, but you know, even if they, you know, they're gonna be showing up in the morning and asking why it wasn't done overnight, and sometimes, you know, there's not enough staffing in imaging. Or like, what happened to these labs? Like, I need this and that. Like, and it's like, okay, stop yelling at me, I just clocked in, I don't know what's going on yet. To kind of take that and, okay, I'm gonna make the moves, I'm gonna make the phone calls that I need to make, and then leave it at that and not let it get too personal, because it's really not about you. That doctor's been following that patient's care for, you know, multiple days now. There are things that are out of your control, and you know, there's no point in arguing with them and saying, you know, I have nothing to do with this, don't yell at me, whatever. You can respectfully, you know, say what's on your mind and say, you know, this was night shift, this is my first day with them. I will do everything that I can to expedite the process, and just be professional and courteous, and they will see that and take you seriously too. But just know that, you know, you're dealing with really sick patients, you have to move things along so that way we can figure out what's wrong with them. Also, especially starting out, it's not really a 12-hour shift, guys. It's more of a 13, 14-hour shift. When you start out and you're just learning how to chart, you're trying to put the whole puzzle piece together, it does take time, and sometimes you don't end at the same time that all these other nurses, and they're all leaving at the time that they're supposed to leave, but you might still be there stuck charting or passing your last med because you are, you know, you were backed up all day, or you had an emergency, a situation happened. This still happens. I mean, you might just get an admission like right at shift change, and you want another thing. Just because they're critical care doesn't mean that they don't get, these units don't get as many discharges as other units. You still get a lot of discharges. In my previous unit, the cardiac unit, where there were LVADs and stuff, I didn't really do a lot of discharges or admissions. When I moved to another unit that was still PCU, but also had some med-tele patients, but mostly PCUs. Now that I'm working in a full PCU floor, we have a lot of discharges and admissions, and sometimes I will discharge 2 or 3 of my patients out of 4, and then I get another admission right after that, and then another one after that, and it's very, very hard to catch up when you're, you know, you have your other patients too, and they all have their needs, and you have your own needs. You have to eat and pee and stuff, and then you're just getting slammed with admissions. And I know exactly what it's like to be on the other end of that, where you're assigning patients to nurses, and you know, you have to do what you have to do. Okay, another thing that kind of hit me was you're not always gonna get that 4-to-1 ratio where you get 4 patients to 1 nurse in PCU just because you're PCU. No, you're still gonna get stretched. Sometimes you're gonna get 5 patients. That's gonna be tough because they're critical patients. You might be making like serious life saving moves and they may not even say thank you, and their families may not even say thank you, and even though they know exactly what's going on, you may not even get a thank you. So, or I appreciate what you're doing. And oftentimes you will, you know, there are those patients and those families, and they're very appreciative, and they, you know, ask you about how, you know, if you had lunch, or tell you to, you know, have a good night when you leave. And that's always great when you have those patients that appreciate what you do. It's very rewarding. It makes you feel like you did what you did for them, and it's worth it, that it's all worth it. In the end, you know, like I said in the previous video, it's a passion kind of profession. You don't do it just because you got paid for it, because clearly nurses don't get paid enough for what they do. We do way more than we're supposed to. We do way more than than what's on our job description in our profession. We, like I said, we have multiple roles. So, don't be discouraged if these things happen. That's just kind of the nature of this world. Sad to say it, but it is what it is, and I'd rather say it out loud to, so people know and can hear how it is, than people be misled and they go into nursing school and go into this profession and they're miserable, and it's because they didn't know these things. But I know them. I'm still here. I still love nursing. Now, do I love how nursing is going in this weird direction nowadays? It's very political. It's about staffing, and there's just so much to it. It's just not what it used to be like before, years back, before I was even a nurse. So there are a lot of changes that have been happening, and you just have to find what's right for you. You have to do a lot of research, but these are just a few things. I'm gonna stop this video because I don't have that much memory left. I gotta be quick. Okay, so if you guys have video suggestions, I would gladly appreciate them. If you guys could leave them in the comments down below. Thank you so much for watching. If anybody wants to subscribe so you can know when I post stuff like this, I will try to post every week if I can. I'm trying to get consistent with this so that my videos get out there and people can hear everything I have to say about these kinds of topics. So without rambling on and on even further, I'm gonna go and say goodbye. Thank you so much for watching. Bye.